So when the newborn, once you write the resuscitation and maternal details, you'll be going for the physical exam entry. So birth weight, head circumference and length, which are initially documented, should be entered in the first day's notes. The gestational age should be entered, and if you need to confirm by a modified Ballard score, you can enter the score there as well. The vital signs are usually recorded by the nurses, and you can transfer it here. Heart rate, respiratory rate, whether there is any feature of respiratory distress, saturation, temperature and blood pressure. The general assessment of the newborn will include assessment of the skin for rashes or lesions. Sometimes you get cuts from the birth or bruising. You can document that as well. You can also mention the presence of spinal tuft of hair or dimples, which may suggest underlying spina bifida, and also look for early jaundice. You can refer my recent talk on the AAP update on jaundice management. Then you look at the head, ear, eyes, nose and throat. So the red reflex should be examined either at the initial assessment or within the next assessment, so we don't miss it. We should look for it bilaterally. External ears for presence of pits, anterior fontanelle, presence of molding. So molding is more to reassure the family, they'll be worried about the head shape. Cephalometoma also should be explained clearly to the family. You can refer my videos on these topics as well. So look at the hard palate. You may need to feel it with a gloved finger or use a tongue depressor to see it clearly with a good light. The ophthalmoscope light is quite useful for this as well. Assess the neck for any concerns. Examination of the cardiovascular system, including the capillary filling time, heart sounds, presence of murmur, presence of pulses, both central and peripheral. And remember that the presence of femoral pulse in the first day doesn't rule out coarctation. Obviously, you need to examine the baby pre-discharge, and the saturation screening is important here as well. In terms of the respiratory system, you evaluate the chest shape, symmetry, air entry, presence of added sounds, any distress features. You can refer my playlist on respiratory distress, and additional sounds like stridor. Assessment of the abdomen should mention whether there is soft, full, tense abdomen, whether there is any mass, organomegaly, and bowel sound should be listened to as well. You may have to listen for a little extended period of time to hear the bowel sounds. And abdominal girth, if you're measuring for any reason, you can mention it. In terms of genitourinary, we should assess the genitals in both boys and girls and specify if they are appropriate for the gender and gestation. Some degree of clitoromegaly is normal in growth restricted female babies. And if there is any ambiguity or anything, you should be mentioning it clearly, and further plan should be according to the examination findings. The hernial orifice assessment is most important in the preterm babies who are approaching discharge, and in the initial stages it's not common. Of course, you may get hydrocele in many babies, and you should differentiate it from a hernia. Hip assessment, including the Ortolani and Barlow's assessments, and then neurologic assessments including sensorium, responsiveness, variation in state, tone, both active and passive tone, newborn reflexes including the Moro, and reflexes including gallant, suck, root, gag, as well as a pupillary size and reaction. The head circumference should be documented. I'll be making a video soon on neurologic assessment of the newborn.